Hi, my name is Yuna and I'll be teaching today on the challenges associated with inverted nipples and how that affects breastfeeding with preterm infants. This breastfeeding challenge will then be applied to the situated clinical decision-making framework to guide clinical practice. First, we're going to start with knowledge. Knowledge is defined as knowing the challenge, case, and the various factors that influence the effectiveness of infant feeding. What are inverted nipples? An inverted nipple is a nipple that does not protrude outward. A mother may acquire nipple inversion as a result of trauma, inflammation, malignancy, or surgery, or the mother may have been born with inverted nipples. So how does that affect breastfeeding? The nipple needs to stretch so that it reaches the junction of the infant's hard and soft palate. There are two things that can result from a nipple not being able to stretch. First, the infant latches poorly, causing damage to the nipple, resulting in pain for the mother, or the infant does not get the stimulus to suck and is not functionally latched to the breast. However, not all infants experience the same problem, and some infants can draw the nipple out by latching. Also, regardless of how the nipple looks, it is important not to draw conclusions about the potential for breastfeeding success. Babies breastfeed, they don't nipple feed. Next, we will address how prematurity affects infant feeding. A preterm infant is defined as an infant born between 37 weeks gestation, and a late preterm infant is an infant that is born between 34 and 36 weeks gestation. These infants are more likely to have problems with feeding ability. This is due to their neurologic immaturity. Premature infants are unable to maintain an awake, alert state and demonstrate enough energy for feeding. Also, premature infants will have weak oral motor skills. This leads to poor coordination of the suck, swallow, and breathing reflex. All of these factors may lead to a breastfeeding challenge. These breastfeeding challenges can lead to acute problems such as hypoglycemia and prolonged jaundice. Now that we have an understanding of how these challenges affect breastfeeding, we can now look at some cues that present that a breastfeeding challenge exists. These cues will help us identify any breastfeeding difficulties that are due to inverted nipples or prematurity. These cues are determined by looking for signs, symptoms, and assessment and lab data. First, we can assess the mother for inverted nipples by compressing the mother's areola. If her nipple inverts upon compression, she is considered to have inverted nipples. The nipple will not become erect when stimulated. This can also be another sign that the mother may have nipple inversion. Another sign that is specific to the mother is a decreased breast milk supply. A truly inverted nipple may have fewer breast milk ducts. Also, the mother may show signs of areolar edema, which may be due to engorgement. This causes the nipple ducts to collapse or become occluded. Overall, because these challenges exist, the mother may seem less confident about her ability to breastfeed. We can also look at the infant cues that are being created related to their prematurity or due to inverted nipples. These cues may include a sleepy baby, initially feeding well, then tires shortly, inadequate output, which is shown by the number of wet diapers, and weight loss or decreased weight gain appropriate to gestational age. Also, a blood test may indicate hyperbilirubinemia. Lastly, the feeding relationship between the mother and infant may be an indicator for an existing breastfeeding challenge. Some indicators of a challenge may include having difficulty latching, breast refusal from the infant, and an overall frustrating experience for both the mother and the infant. These cues will help us judge what is happening within the situation. Judgment helps determine what is happening within the situation that is contributing to the breastfeeding challenge. In the judgment portion of the clinical decision-making process, we will be exploring the effects of the breastfeeding challenge on the mother, the baby, and on the feeding relationship. We will also determine whom we can consult and the priorities that exist. First, we will be examining the mother. A mother with inverted nipples may experience difficulty in her latch. This may lead to inadequate breast emptying. This may inhibit milk production and interfere with the supply meets demand system. With the infant's neurological immaturity may be inhibiting the infant's ability to maintain an awake, alert state and direct attention to the feeding process. Therefore, the infant may not be able to feed long enough or often enough. Also, because of the mother's inverted nipples, the infant may not be stimulated to suck. Within the feeding relationship, there may be less breast stimulation because of the mother's inverted nipples, and there may be delays in the number of oral feeding opportunities because of the infant's prematurity and their availability within the NICU. This will decrease the number of skin-to-skin opportunities, time spent bonding, and overall number of times that the infant is fed at the breast. Overall, these factors may contribute to less milk production and to the breastfeeding challenge. A lactation consultant should be consulted in the immediate postpartum period so that any latch problems can be addressed and breastfeeding can be successfully initiated. The 3 priorities that exist for both the mother and the infant are to 1. Feed the infant, 2. Move the milk, and 3. Help the dyad learn to breastfeed. These priorities can support the mother and infant when there are challenges with the latch and can guide decision-making when helping the mother and infant dyad learn to breastfeed. In this next step, we can determine how we can help the infant and mother overcome this breastfeeding challenge. In order to feed the infant, we have to recognize that many preterm infants cannot suck well enough to breastfeed or bottle feed until they have matured physically to the corrected age of more than 32 weeks gestation. This is due to their undeveloped suck, swallow, and breathing reflex. Although they may be not able to coordinate these reflexes, breast milk and skin-to-skin contact should be encouraged. Skin-to-skin contact can enhance milk production and provide other benefits that will be explored later on. Enhancing milk production is significant because human milk is the ideal food for preterm infants. Breast milk has benefits that are unique to the infant. It enhances development and promotes physiological stability. It also decreases the risk of acquiring infections and other diseases that preterm infants are vulnerable to. To feed the infant, some preterm infants will require gavage feeding as a method of providing nourishment. Gavage feeding is usually required when an infant is easily fatigued by sucking or is unable to coordinate its suck, swallow, and breathing reflex. In gavage feeding, expressed breast milk or formula is given to the infant through a nasogastric tube. In time, these infants will develop their suck, swallow, and breathing reflex. As they begin to mature, some preterm infants will be capable of breastfeeding for at least some feedings per day. These infants tend to be sleepy with minimal and short wakeful periods, and these factors can contribute to inadequate milk intake. Therefore, the infant may need to be supplemented, and to do that we can offer other methods of infant feeding to deliver the breast milk, such as using hand expression or a breast pump to express the milk and then using a spoon, dropper, or syringe to feed the infant until the baby gains weight and is feeding adequately. Some things that the mother can do to increase the effectiveness of her baby's latch are to compress the breast and areola in a C hold. This may stimulate the nipple and can offer the baby as much breast as possible. Other possible methods of elongating the nipple are to use nipple shields and also using breast pumps or breast shells. These can be used to elongate the nipple. Throughout the process, the mother should be moving the milk. The preterm infant may not be available to breastfeed right away due to their acuity. Therefore, the mother should begin pumping her breast as soon as possible after birth. To establish optimal milk supply, the mother should use a dual collection kit, pumping both breasts simultaneously 8 to 12 times per day for the first 10 to 14 days. She should continue to pump regularly until the infant is able to breastfeed effectively. As previously mentioned, skin-to-skin contact can help enhance the milk production. However, it can also help the dyad learn to breastfeed. Skin-to-skin contact can allow the parent to become more aware of their infant's cues. Along with skin-to-skin contact, parents should also be encouraged to be involved in routine interactions with their infant, such as holding their infant or changing a diaper when the opportunity presents itself. Because infants are in the NICU or are acutely ill, these opportunities are often very rare. However, they are important in establishing a bond between the mother and infant and allowing the mother to respond to the subtle cues her infant may be making in response to their needs. Lastly, we can determine the effectiveness of our interventions by evaluating the outcomes. Some of these outcomes will include appropriate weight gain or weight loss according to the infant's gestational age and an appropriate amount of wet diapers, and the mother may be producing more milk according to her breast pumping ability. In conclusion, the process of providing breast milk to a preterm infant with the added challenge of having inverted nipples may make the journey frustrating and long. However, we need to reinforce the idea that her inverted nipples will not impair her ability to breastfeed her infant, but that it is a challenge that can be overcome. So that concludes my presentation. Thank you for watching. Bye.